Amazing. Thank you, everyone. This is Amanda, because I'm in the chief office, so I cannot lower my mask, sorry. And then today, Sandy and I gonna do the afternoon report together. So we're gonna share a case. Let's start with a core complaint. So this is a patient with acute onset right knee pain and swelling for a day. So let's give a little bit of more information. So this is actually an elderly gentleman with history of type 2 diabetes, hypertension, hyperlipidemia, CKD3 osteoarthritis, and then presented with right knee pain and swelling for 1 day. So like when we having such like a case with like patient presenting with acute onset of knee pain, what kind of question or history you would like to obtain from the patient? Anyone would like to volunteer?
Any fever, any stiffness, any changes in the color around the knee, any skin changes around it, any recent trauma to the knee, for any prior events? Is this something new, something that has been going on for a while? Any other joints affected besides this one? Yeah, sexual history, as David said.
Amazing, great, thank you. So basically he covered almost like everything. So like, cause this is like a rheumatoid cases. So first it's a pain case. For any kind of pain, we need to ask about the onset, about the location, and also like any associated symptom, and definitely some other past medical history, associated sexual history. Those are very like important as well. So let's give a little bit of more information regarding this patient. So this patient is actually very interesting because initially he was not admitted for joint pain. So this patient was actually initially admitted 5 days ago for cellulitis. And then he got the IV cefazolin, and then the symptom of the cellulitis kind of improving. But when he's still in the hospital, he having this like acute onset of like atraumatic right knee pain, swelling. It just developed very quickly overnight. And then this patient cannot ambulate by himself. So that's why the rheumatology consult has been called. So when we further asked him about the history, so he actually having similar episode of knee pain in the past 2 years, involving like one knee at the same time, but it can be left knee, it can be right knee. And then this patient like see the doctor, he take over-the-counter painkiller. He was also been diagnosed of osteoarthritis about like 6 months ago when he went to see the rheumatologist. And then the rheumatologist actually want to tap him as outpatient, but the patient refused. He doesn't like needles, so he refused all the procedures. And then this patient was treated with some like topical NSAIDs and also outpatient therapy. And this patient like have all the symptoms improve with all this like conservative treatment. He also endorsing some like chronic lower back pain and then right wrist pain. So any further question you want to ask regarding this patient, like before we jump into the like past medical history stuff? Any further symptom you want to ask?
If you're aware of the chat as well, if you want to take a look, or I can help you with that. There are a few questions that were asked before. Are they using anticoagulants? I guess we'll go into the surgical.
Yeah, this patient was not an anticoagulant.
We'll go into the surgical history or whether they had any prosthesis placed before.
So this patient had a history of left foot fracture, status post like a close reduction, but that's like 10 years ago. He doesn't have any trauma to the knee this time. Sexual history is not significant. This patient is only sexually active with his wife. Prior episode, yeah, as mentioned, like this patient actually having very similar episode, three episodes in the past 2 years.
Got some
There's
questions,
no-
so that makes it easier. Other than that, how were they diagnosed for OA? Is it a clinical diagnosis? Did they see anything on X-rays? Ventage's question.
It's a clinical diagnosis. So this patient have their knee pain, and then the X-ray showing some like spur, and also some like the radiographic changes suggesting osteoarthritis.
They're afraid of
Patient
knee.
never,
Mhm.
yeah, and the patient never got tapped before.
They had any recent infections? I know you spoke about STIs, but any diarrhea or any other infectious process?
No diarrhea, no history of sexually transmitted disease. The only recent infection is the cellulitis of the left foot, the other leg.
Kirsten is asking what the characteristics are. Does it migrate from one joint to another? Or does it happen all at once at both joints? So symmetry of the pain.
So there isn't any other joint involvement. This patient, the pain is only limited to their right knee. There's no migration.
So all the pain that's happened in the
you-
past has been in the same knee. Any rashes, mouth sores? Fatma's asking.
No rash, no mouth sore.
Thinking
No
systemic.
fever, no tendonitis.
Perfect. So I guess there was some mention of right wrist pain and the chronic pain that the patient had reported. Did they give you any more information about this?
Sorry, please say that again.
There was some report of right wrist pain and that chronic lower back pain.
So this is actually like pretty vague presentation. So the patient is only like endorsing some lower back pain. It's been like on and off, like worsening with exercise. And the right wrist pain, the patient doesn't really know when the right wrist pain, the onset of right wrist pain, it's been also pretty chronic.
This time. So we're going to focus on the knee pain then. I guess Rohit had a question regarding that back pain, which you just answered. It does worsen with exercise. We don't know if there's any stiffness. This knee pain, does it get worse with activity?
There's no stiffness of the back pain. This patient, like we can actually from the physical examination part, this patient have like a slightly neck stiffness, but there's no lower back stiffness. Patient also not endorsing any like morning stiffness of any of the joint. And then their pain, the back pain was actually worsened with exercise. Right. There's no change in weight.
Other systemic symptoms that the patient might have reported? I think we've said no to most of them, but
No. There's no systemic symptoms, no GI symptoms. Yes.
any other questions may come up, you feel free to write them in the chat. Oh, there we go, Nick. He wants to know if that right wrist pain, did the wrist swell up as well?
No, the wrist was not swollen.
It's like a chronic unrelated incident from what we can gather in the history. Maybe it's.
Mm-hmm.
Want to move on and feel free to post more questions in the chat.
Yep. So like, let's talk about more about our, oh, I need to close this one. Okay. So like, let's move on to some more information regarding the background. Actually, there's a few like information you've been asked already. So as for the past medical history, this patient only significant for diabetes, CKD osteoarthritis, and then he had a left foot fracture because of trauma, and then had a surgery done 8 years ago. There's no family history of any rheumatoid stuff, no lupus, no rheumatoid arthritis, no like IBDs. Sexually history, social history, sorry. The patient quit smoking 10 years ago, and it's only like a social drinker, not using any recreational drugs, not involving in like dangerous high-risk sexual activities. Medication-wise, this patient doesn't have any recent medication changes. Home medication only including amlodipine, and also some insulin for his diabetes, metformin for diabetes, Lipitor, and also some PRN, Tylenol, lidocaine patch, and topical NSAID for pain. The only recent medication change is only the cefazolin the patient received while he's inpatient for his cellulitis. This patient doesn't have any history of allergy. Okay. Any further question regarding the history before we move to the physical examination?
And he wants to go back to the wrist pain. Is it associated with the outpatient diagnosis of osteoarthritis, or did this happen more recently?
No, the wrist pain actually was not really the reason he's been diagnosed with osteoarthritis. So I went back to his care elsewhere, the outpatient now. It's actually diagnosed when this patient had a trauma of the knee, and then the outpatient physician did an X-ray, and then diagnosed the patient with osteoarthritis. So when they diagnosed with the osteoarthritis, actually they didn't even mention the wrist pain from their note, but from what the patient telling me, the wrist pain was been like on and off, and then been intermittent, been a while. Like, I mean, been a while, meaning like probably for a few years. The patient doesn't even know when their pain started. No change.
You mentioned the spur in their X-ray before. Kirsten wants to know if there's anything else that they saw on that X-ray they did a few years ago.
So because the reason we don't really have the image for the X-ray a few years ago. So not a few years ago. Actually, he did an X-ray 6 months ago to diagnose the osteoarthritis. Except for I don't really remember, except for osteoarthritis, this patient having any other significant changes, because there's no image. We don't really know how much we can really trust the report.
Kirsten, what were you thinking about? I'm curious. I mean, we're taking all the reports of the grain of salt.
Yeah, I mean, I was thinking he has OA, he has diabetes, and this like recurrent knee pain. If there was like calcium pyrophosphate crystal depositions, if there were any changes in that regard.
What would you say that looks like in an X-ray?
There's like I forget the exact word for it, but there's like a band like thickening, or yeah.
There's almost like calcification in that soft tissue. There you go. Chondrocalcinosis.
Chondrocalcinosis, yeah.
Thank you.
Thank you, Rebecca.
Well, so we don't know, right? We don't have the images. We kind of have to see what's going on acutely. That's a good point, though. Very good point. If you want to move on, if there are no other
questions. On to the physical examination. So next is the physical examination. So this patient vitals been pretty well, afebrile, and then doesn't appear in the stress. The lungs and heart are pretty clear. There's no crackles of the lungs. There's the GI system is also pretty unrevealing. The neural system, the patient L times 3, moving all extremity freely. We don't really do like very thorough neural exam. Skin-wise, this patient doesn't have any new skin changes, and then there's no like palpable lymph node appreciated. MSK system for the right knee. This patient has significant swelling and erythema, tenderness of his right knee. The range of motion was like significant decrease because of the pain and also the effusion. This patient have like a palpable, like moderate effusion, definitely tappable. The other drawing, this patient also have like a left dorsal foot tenderness. from what the patient telling us, actually that is the site have been diagnosed of cellulitis, and then their tenderness is already improving with antibiotic infusion. This patient also having some pretty vague C-spine stiffness. There's no deformity, swelling, tenderness on palpation to outer joint, not to the elbow, wrist, fingers, or the left knee or ankles. And also this patient actually doesn't really having tenderness to the lower back pain when we're doing the physical examination. Okay, so anyone would volunteer to summarize what we found from the history and also from the physical examination?
Well, people think about if they want to volunteer, or I can pick someone. Yeah. One second, Christopher. One second, Christopher. We're gonna just read off Ariela's question before we move on. She wants to know about the C-spine stiffness. Is this nuchal rigidity, or do you see any swelling of the neck? Anything else going on there?
It's not really the nuchal rigidity. So there's no significant swelling. And then from what the patient telling us, actually, it's because the pillow in the hospital is not really comfortable. So that's why how he developed the stiffness in their neck. But there's no a red flag symptom or signs to the neck. And then there's no significant point tenderness of the C-spine.
Questions are coming up in the chat.
Yeah, that's a good question, but honestly, I didn't really pay much attention to the CKD. It's probably most likely from diagnosis. But I really forgot the information regarding the CKD diagnosis. Sorry for that.
I think, Randy, they read in the exam that there was no point tenderness. Yeah. Well, this is very good. You guys are doing a focused physical exam. Obviously, we need to pay attention to all those systemic symptoms and signs. If you're saying that there is limitation to the range of movement of the knee, or you said it was decreased, how do you calculate this limitation? Do you have angles? Does he prefer to keep the knee flexed or extended? Ariela is asking. Ariela, if you don't mind, will you be okay to unmute yourself and tell us what is your train of thought here? Why you're asking these questions? Or what do you think this will give you, how this will give you more information?
No, I don't mind. Hello. So I think it can be helpful in terms of different causes of knee pain and effusion. So not that I've seen too many septic knee joints, but I think that they're particularly tender. Usually the patients like to keep them more extended than flexed. And if there is, and I think the more range of motion the person has, the less you're thinking of septic knee joint pain. So I was just wondering if there's any more information with that.
Yeah, thank you. So actually this patient prefer the knee to be extended. So whenever we bend their knee more than 90 degrees, this patient will having very significant pain and then kind of limit our examination. So he himself is always extended their knee and then kind of refusing us to bend it.
I was asking if you had noticed any changes in the nail bed, anything on physical exam in the extremities?
That's a good question. So this patient doesn't have any nail changes. So what's in your mind when you ask this question?
So how would this help your differential diagnosis if you did see changes in their nails? And what kind of changes are you thinking about, if you don't mind sharing?
Yeah, I was thinking about psoriasis. Sometimes you can have changes in the nails without having rashes necessarily, typical of psoriasis. So that's what I was concerned about.
That's a very good thought. And then we should always like take a look at patients' nail when we see any kind of like rheumatoid cases. And then definitely we need to do almost like a full skin check. Because sometimes if this patient having some rashes like on the back or some like behind his thigh or something, this patient himself might not even notice. So it's always great to take a look at all the nails and also all the skins. That's a good point. How bad was the cellulitis? Any concern for bacteremia? So the cellulitis, because from what I can see, because when I saw the patient already getting IV antibiotics for 4 or 5 days. So actually the cellulitis is not that significant when I saw him, but like compared to the photo they uploaded to media on a mission, that looks pretty bad on a mission, but still there's no like purine discharge. It's just like a pretty red and swelling. Any concern for bacteremia? So they send their blood culture on a mission, and then from the culture on a mission, the patient doesn't really having the culture was still non-grown to date 4 or 5 days after. So we would presume this patient doesn't have bacteremia.
You had a low threshold to look for bacteremia and what seems like a resolving infection. They might not have a fever, which is what we're seeing here. Other signs, but you still would, I think it would still warrant a diagnosis, like labs, imaging, and I'm assuming we got Amanda, right? And perhaps Christopher, are you still around?
Excuse me?
Sorry for interrupting your problem or presentation before. Do you think you're up for it again?
No, actually I had a question, but it was answered already.
Oh, I'm sorry, Chris. Well, now that we have you here, do you think you'd be up to do the problem representation? In the spot tonight.
This is a 76-year-old man with past medical history of hypertension, diabetes, CKD, and also history of joint pain, and it's being managed as osteoarthritis, and recently admitted for the management of cellulitis, presenting with right knee pain and swelling for 1 day, which is concerning for worsening osteoarthritis flare versus crystal arthropathy, pseudo gout or gout.
Thank you so much, Chris. Amanda, what do you think?
Pretty good. Thank you for even offering the differential diagnosis in this case. That's pretty great. So here's the one I summarized. I didn't really mention the differential diagnosis. Sorry. So basically, this is like very good summary from Chris already. So here's just like a little bit like a shorter version. So this patient is like elderly male with history of diabetes, CKD, osteoarthritis, and also there's a recurrent knee pain attacks, and also had a recent left cellulitis, presented with acute onset of right knee pains, erythema, and also moderate effusion.
I have a question actually. Based on the physical exam, wouldn't you maybe want to call it oligoarthritis? Like a few, I think we have maybe enough evidence of other joints being involved.
How many joints
I would probably call this still mono arthritis, because honestly, there's one very specific joint pain. Even though this patient probably having some other joint pain, but we do not really think that's related. So I would still probably call it like monoarthritis in this specific case. Because in real life practice, some patient always complaining of some vague joint symptom. But his right knee pain compared to the left foot pain, the C-spine stiffness, doesn't really sounds like really related. And then like also for the C-spine stiffness and also the left foot tenderness, we have some other explanation for them already. So that's how we probably would not like summarize into the same joint pain and the same group of joint pain. And that's my thought, sorry.
Okay, thanks.
Can I ask a last question?
Sure.
So we say it's 1 day history of this knee pain and acute onset. My question is, how acute is it? Like from 0 to 10, how fast did it go from 0 to 10?
That's a very good question. So it's a really rapid onset. So basically this patient like before he went to bed, he's still symptom free, completely asymptomatic. And then the next morning when he woke up, he already having this very debilitating extreme pain. So I would say a few hours.
So why is that an important question to ask?
There are a few diagnoses that would cause these few conditions. Gout is very well known to go from 0 to 100 in very few hours, so that's why.
And which other things are going to go that quickly besides gout?
Pseudogout takes a little bit longer, but I don't know, septic arthritis maybe also takes a little bit longer. I'm not sure if there's something that peculiar about other than
Take that much longer. A septic joint can develop over the course of a few hours.
okay.
Thank you. That's a very good point. So that's why we always need to ask the onset of the symptom and see whether this patient have the really like acute onset, or it's more of like a subacute onset, or it's actually acute on chronic, or it's actually chronic. Always important to ask about the onset of the symptom. Okay, cool. So wait.
There's other things that can also swell up quickly, but not give you the signs of inflammation, right? So you can have a meniscal tear that's going to cause a huge joint effusion over the course of a few hours, but it's not really going to look like a septic joint, right? It might be painful and it might be swollen, but it's not usually going to be hot and red. You know, and there's some other internal derangements that can do it, but they're going to look very different.
And the time will help you determine, or will help you get to your diagnosis, because the ligaments also swell up faster than the meniscus when it tears, and hemarthrosis.
So next we could like start talking about the differentials regarding the knee pain. Sandy, do you want to share the slide or share the whiteboard or something?
Go to your next slide. I think you
because the next slides are already the basic labs. Oh, I actually hide a slide with the algorithm. You want me to show that one?
I really like that slide you were sharing.
Oh, let me just like show it then. 1 second. It's the algorithm you want me to show, right?
It's a cool algorithm, guys, from Up to Date. I have it as well, if not.
Sure, just give me 1 second. Here we go. You see it?
So here, I thought this is really cool that you brought this up. You guys can see how Up to Date will tell you, well, if you have an adult that comes in with knee pain, obviously if it's a high energy trauma, so think, you know, car accident or skiing accident, someone that falls from like, they'll need an evaluation. Like there's certain tests that you need to get because you might need a surgery referral for these patients. For patients that do not have any associated acute trauma, like our case, then you can check their knee and see if there's an effusion present. And we'll talk more about the physical examination. When you do detect an effusion, there's certain questions that you guys already asked that were quite on point. does this increase with activity instead of mechanical pain? In these cases, we can think about OA, which we know will be associated at times with an effusion. Now, other types of osteochondral injuries can also cause an effusion, and the pain will be that kind of mechanical pain that gets worse when the patient is ambulating or with physical activity. Now, in cases where the pain is not necessarily related with activity, you may consider other systemic things. Here we have the crystal arthropathies that Christopher brought up in his differential diagnosis. Just arthritis, right? We talked about that red swollen knee, and we talked about how this is a medical emergency. And again, other systemic rheumatic or rheumatologic processes that you guys also brought up that you would have found in your physical diagnosis, in your physical examination, right? So this is a good way to start. Obviously, once you don't see an effusion, then you'll have to do a physical examination to better locate where these, I just noticed in my screen, so you're not seeing my, my mouse, but will you see where the pain is located? And there's several maneuvers that you what the disease is. Now, if you want, I can now share my screen. Again, this is up to date. It's pretty good. May I take over, Amanda? That's okay. Looking at the screen that says knee pain with the computer. Wonderful. All right. So the knee, it's a relatively simple joint. And if we think about its anatomy, we really have to think about 4 different bones. We have the femur, the fibula, the tibia, and of course the patella. You have to think about 2 tendons, 4 different ligaments. So we're thinking collateral and cruciate. And you have to think of the 2 different types of cartilage that we have. I think of that coating of the articular surface, and that's around the femur, and we'll see the tibia area. We'll talk more about this. Have the meniscus. They kind of sit on top of the tibia, like 2 rubbery horseshoe shaped caps, sort of how we describe it. So I'm a big fan of the curbsiders, and they have podcasts on everything musculoskeletal, and I highly recommend taking a look. I had linked this, and you guys, if you go on pressy.com and just type my name, you'll be able to find the presentation and click on the links. It'll be probably easier, but if not, this is podcast 274. And in this chapter, they had a guest speaker who's an orthopedic surgeon, and it's filled with clinical pearls. Check it out. He'll break down, any kind of larger joint pain into simple next steps in terms of diagnosis and management. Now, what I liked about them is that they'll tell us that the first rule is always to diagnose or rule out emergencies. In this case, we mentioned septic arthritis and we mentioned fractures, so trauma. These are easier to tell because the patient will come in with this swollen, red, sometimes tense joint. And then they'll tell you, obviously, it feels really uncomfortable. And in the majority of cases, it might not even be able to walk, right? So always be on the lookout for these red flags because we'll need more tests. And like we saw in our up-to-date management schema, they'll need more of a, like I said, a workup and maybe even a surgery referral. Now, they use 4 different buckets to kind of...
Let me just say, the one you might occasionally miss, you have to be on the lookout for it, are patellar fractures, because people can actually walk in with those, but they'll usually have very localized pain on the patella. That's usually when they fell onto the patella, but you have to make sure you do specific x-rays looking for that, because otherwise you can miss it.
I think you need a very high energy trauma or fall for that to happen, right? To break the patella.
It doesn't have to be as high energy as you think, especially in older people.
Definitely something to be on the lookout for. Well, I was always saying they have like 4 different buckets. They have osteoarthritis, patellofemoral syndromes. They have meniscus tears and ligamentous injuries here. Now, and like I said, if you go into the podcast, they'll talk more about the diagnosis and treatment for these injuries. If we go into our first bucket, we're talking about the ligamentous injuries now. They're usually easier to separate from other patients who complain about knee pain. As you may or not remember, the role of our knee cruciate and collateral ligaments is sort of to stabilize that joint, right? So these structures are connecting the 2 bones so that they can have normal motion, right? So it's either flexion or extension. But they're also there to resist what would be an abnormal motion. And it's really hard to show this on camera. So I kind of included what hyperextension looks like, varus and valgus, and then that anterior posterior translation. And that's an abnormal translational and rotational movement. Now, as we see here, the MCL will prevent a deformity that's called a valgus deformity. Now in Spanish, there's a word for worthy, that's valuable. And that's usually how I remember. If you remember the Spanish word valuable, you know that someone that knows their worth has a little bit of an insight. So they go towards themselves. And then the lateral collateral ligament will prevent a varus deformity. We know that the collateral ligaments work around here, but we also have the cruciate ligaments who will prevent that anterior and posterior translational movement. So they'll keep the joint sort of stabilized. Now, let's see if I can move to the next. Like I said before, it's easier to identify these patients. You have to know that the knee ligaments are about the same length and the same diameter as the patient's pinky finger. So it's quite difficult to tear a ligament unless you have substantial trauma. Now, a patient that has knee pain but has had no trauma is likely not to have a ligamentous injury, but maybe not acute. Know what happened in the past. Some patients come in and they'll tell you that they had, you know, a knee sprain years ago and that it healed, but ever since they just can't use their knee very well, and sometimes it just gives out. And even some patients will even tell you, well, it's painful and it swells up, and then it kind of just goes away, right? And this is a classic history for someone that has had a chronic ligament deficient knee. So these patients, they had initial swelling and they had initial, pain with their injury that kind of never resolved. The ligament didn't heal well. So they may be prone to these episodes of instability. So the knee's giving out. Some patients may even tell you they felt or even heard a pop when they hurt their knees. So the knee ligaments, like I said, they have a substantial diameter and they can store a lot of energy there. So when the ligament fails or when it is injured, then it kind of releases all the stored energy, and that's what creates that pop that the patient sees. Now, it's not pathognomonic. An important clue that may suggest that what was injured was actually the ligament. We talked about this before. An effusion and the time of onset of that effusion may also be an important clue, because we know that this also is part of the meniscal tear. You have to know that ligaments are more vascular than the meniscal tissue, and therefore patients that have an injury of the ligament will develop that effusion within an hour or rapidly. In patients that tear their meniscus, this will probably be a slower process. So again, clues to help us kind of determine what's going on. Now, when we are examining these ligaments, and I'm including pictures because I can't show you in person. So you see here, for you to test the MCL, place a hand in the lower part of the leg, and then you pull it away from the midline, while you're using your other hand to push the thigh towards the midline. So you're creating this motion. And with this, you're testing the medial ligament. To test the lateral collateral ligament, you'll do the opposite, right? You will push in with your lower hand, and then you will pull on with your upper hand so that you're taking the thigh away from the midline.
So the thing to remember about this one is the knee has to be slightly bent, because if you're doing it with a completely straight knee, then their knee is locked and you're not going to be able to test the ligament. So the knee has to be bent at about 20 to 30 degrees, and then you're going to test the medial and lateral collateral ligament.
Dr. Andrelli. Two things that you are looking for, amount of displacement and quality of the endpoint. So ligaments are not perfectly rigid, so you will have some elasticity as you're applying pressure or you're applying some sort of force there. But we should probably be not to what we perceive as normal, but to the other knee. So the non-injured knee becomes our gold standard. There's several, just like Dr. Andrelli pointed, there's several tips to the examination. I'll give you some reference at the end of the presentation so that you can take a look. We can measure all these things, and there's a reference for all our physical maneuvers. There's a lot of variability, like we said, in the ligaments from one person to the other, but having that little variability in the same person that you're examining will kind of help you see if that's what the examination is pointing towards. Now, the cruciate ligaments will resist that anterior and posterior translation of the tibia, right? So I was reading, we use the anterior drawer test, and apparently it's being based by the last reflex. But basically, they're both examining the same ligaments, and they're both having the same maneuver where you're pulling on the ACL, you're pulling on the tibia anteriorly, so that you're kind of tightening the ACL. And that'll let you know, again, compared with the gold standard, which is the non-injured knee, you know, how the, if there's an abnormal translational movement there. Now, those are the ligamentous injuries. In their second bucket, they have the meniscal injury, which is usually a weight-bearing twisting injury. Now, I'm just going to take my. So now some patients with a meniscus tear will tell you that they have that locking or catching or kind of like mechanical symptoms. And sometimes it's because there's a piece, literally a piece of that torn meniscus that's slipping in and out of the joint. So that's what's giving them those mechanical symptoms. There are three ways for detecting, and these are the best ways for detecting one of these tears. One would be the joint line tenderness, pain at the joint line with deep flexion, and the McMurray test. Now, to test for the joint line tenderness, and I would say we would first need to identify where the joint line is. And this is something I learned as doing while I was preparing this presentation. Now, I want you to all try this on yourselves. Ideally, like you see in the image, you would have a 90-degree flexion, but we'll try our best. So maybe you can just cross one leg on top of the other. Now, your patient will be supine in their exam table, and then they'll have their knee lifted up by you. The patella anteriorly. On either side of the very inferior part of your patella, if you can feel it, there's a soft spot. And the reason why we do the 90 degrees, it's because that kind of opens that soft spot. And once you follow that joint line laterally, immediately, and go all the way to the back. And this is what the patients will report when there's a meniscal injury that is painful. So you're kind of eliciting that on your examination. McMurray test, well, it's really hard to describe in words or like even demonstrating it to you guys. So what I'm going to do is going to play a short video that I recommend you guys go back to. And again, the reference will be there. And this is that orthopedic surgeon, and you'll find this in the curbsiders. It's an excellent like 30-second physical exam for the knee. So that might come in handy in your primary care practice. Listen to it. Actually, video.
Take the femur and the tibia together to pinch the meniscus. Our goal is to take the
Sandy, the audio is out.
Can you hear the audio?
No.
Nodded. Anga, you nodded.
We had audio for a second.
That I didn't know.
them together to pinch the meniscus between the two, and then we're going to flex and rotate. So we're kind of grinding the meniscus between the two bones. And this is a test that's hard to learn. In fact, I did it incorrectly for a long time in my practice. The thing that I did incorrectly, when I was shown the McMurray's test, I was taught to put a finger here and a thumb here. That's good. And I was taught to do this sort of combination of flexion extension for the medial side, and this would be it for the lateral side. And that, what I just did for you, is a pretty ineffective test because I didn't do the critical thing, which is to pinch the meniscus between the two bones. I went over here and did this, and all I've done from going here to here is I've rotated the knee in space. The hip's moving and the whole unit has turned, nothing compressed. To do the test right, you've got to go to where his hip won't go any farther, and watch what happens to the skin here as I do that. When I get to that limit and go just a little farther, it compresses. See the compression going there? So that, I need that, okay? I've got to go far enough to get that, okay? So if you don't compress the meniscus between the two bones, the test doesn't work. So it's not the most comfortable thing for the patient, but it's not excruciatingly painful or anything, but you got to get there. You got to get to the end of hip rotational motion and then a little farther to compress. Now that it's compressed, I take the heel and I'm going to draw a big C-shaped arc in the air, okay? And that's a combination of flexion extension and rotation. And I've got a great joystick in my hand to do rotation. I've got his foot. So I'm gonna just, this big C-shaped arc under compression is a great test, sensitive and specific for meniscus. It doesn't work at all if you don't do it right.
It doesn't work at all if you don't do it right. This video again is available for you guys to check. Pressy in my name. And if not, the curbsiders, and you'll find it under knee exam. Bucket 3 is just osteoarthritis. Arthritis in general, you guys know, is the degradation, the wear and tear of that articular cartilage. It's not always just time related, although most commonly that's what we see. Think about rheumatologic conditions, trauma. So again, with greater friction, which is happening because the surfaces don't have that, or they have that worn out cartilage, then the joint, what it does is it will overproduce that thick, viscous joint fluid. And this is sometimes what we see when we do an arthrocentesis to try to better lubricate that area. That extra fluid is what causes the joint capsule to kind of stretch, and that's creating all that pain and that stiffness in our patients. In some of these cases, and you'll see this in your boards and whatever exams that we take, a Baker's cyst may happen, and that's just that fluid being sequestered in the posterior aspect of your knee. Now, joint swelling, stiffness, tenderness, your patients may complain of all these symptoms, but this is specific for osteoarthritis. The one physical exam finding that might be more specific for this is the presence of these severe angular deformities, either varus or valgus. Now, the last bucket will be the patellofemoral joint issues. So either patellofemoral syndrome or patellofemoral OA. Now, I know you guys know this, but the classic example for patellofemoral syndrome, can someone tell me, or do you guys remember from our steps what this patient might sound like? Clinical vignette.
Usually young women who have a history maybe of overuse, more when they like flex and extend their knee or sitting for a prolonged period, and they can have crepitus. Yeah.
That's exactly it, Kirtana. Thank you so much. And actually the pain is worse when they're going downstairs because you have to pull on that tendon and that kind of creates the pain. So what's interesting about this is absolutely all those physical findings that you mentioned. It's sort of like the low back pain of the knee because really our treatments don't work that well. And the best therapy for you guys is to set expectations for your patients. And you will would have to recommend them to strengthen their quadriceps and other muscles surrounding the knee joint so that the pain actually will improve. Now, I'm sorry. Oh, sorry. Yes, Subrat and Rohit, absolutely. Yes, those are that's the clinical scenario. So as the knee, and this is what's causing the pain. Usually as the knee kind of goes through its normal extension and flexion range of motion, our patella glides in a sulcus that's called the femoral sulcus. It's a very shallow groove and it is covered by a thin particular cartilage. It's actually helping that patella move around the bone, the femur. Now, if this is slightly pushed to one side, then you lose sort of that bigger area where the forces of just movement, walking downstairs, squatting, you lose that bigger area and you'll concentrate all these forces in a smaller area around the femur. Tracking patella is really what we explain to them and just strengthening of the muscles. Amanda, you may absolutely, and these are just the references for you guys to check if you're interested. You can definitely take over now.
Could you see the slide properly now? Okay, great. So let's go, but let's go back to our patient. What's in the chart? Oh, okay, cool. So let's go back to our own patient. So here's the basic labs for this patient. So this patient had the white blood cell within normal limit, slightly anemic, hemoglobin 12.3, clinic's been normal, creatinine at baseline. Glucose is actually been pretty well controlled, electrolytes been okay. Magnesium was slightly low, 1.5. Had like a little bit of like mild transaminitis. Also, this patient had a pretty well controlled diabetes with A1C 5.9, ESR 79, and CRP 248. And here's the X-ray of the knee. Someone would like to interpret this knee X-ray?
I see that there is, it looks like there could be calcification on the lateral aspect between the tibia and the femur. And then on the lateral one, it's also visible, lateral view.
Right, pretty great. And then for the lateral view, probably it's a bit like too advanced for like internal medicine lesson because like actually from the lateral view, this patient also having moderate effusion. We can see.
Is that the locency between the patella? Oh, Oh no,
Yeah,
I was.
here's the space. So like normally we can see the ligament normally closer to the bone. And then if we can see this like a space kind of getting more expanded, then we know there's a like moderate effusion here. The left side, we can see this patient actually having this calcification of the cartilage in between the bones. So here's the interpretation of the X-ray from the radiologist. So this patient had a chondrocalcinosis with a moderate effusion, and then the finding are consistent with a calcium pylorophosphate deposition disease. Okay, so like now we having more information. So what's the, and also this patient kind of refusing the orthocentesis at this moment. So giving all the information we had, what's the most likely differential diagnosis in mind?
Septic arthritis is still up there, specifically that he has a very good substrate in his knee. Also pseudo-gout given the pyrophosphate calcium deposition disease. Also, I wouldn't rule out gout before the tap still.
That's perfect. So actually from the X-ray, we know this patient have CPPD, but it couldn't really exclude like a gout and also septic joint in this patient. Because actually with a history of CPPD doesn't really mean the acute flare is also from the acute CPPD flare. It may also from gout and also other more emergent like situation like septic joint. So here's actually, but like given this patient, he doesn't really having any white count, doesn't really having leukocytosis, doesn't really having fever. So we actually thinking it's more like a pseudo gout versus gout. And also giving this patient having history of CKD3. So we start the patient on Salumodrol 20Q12 the first day. So let's go to the second day. So the second day when we saw the the right knee pain only slightly improved. And also he like endorsing some dysuria. Still cannot ambulate by himself, and there's no significant change of his effusion. And then the white blood cells still kind of like normal, but this patient having worsening inflammatory marker, even when he's on steroid. The iron study was kind of like a pointed to iron deficiency picture. The ferritin was mildly elevated, but probably in the setting of acute inflammatory disease. TSH was within normal, PTH was within normal limit. The uric acid was mildly elevated at 7.1. The rheumatoid factor A and A was both negative. Because this patient having dysuria, so we sent a UA. This patient was positive for like a UTI. And then like the primary team resend their blood culture. And then today, because the symptom was not really improving, so now the patient's more amenable for a tap. And then we drain like we tap like 45 cc of fluid and send it for the lab. And then the first day we're having some preliminary reading of the labs. This is like a pretty funky fluid, and then with like a white blood cell 41,000 and with neutrophil predominant. There's only very limited red blood cell, and then this patient having positive monosodium urate crystal. The culture is still pending. So what's in your mind now regarding the differential diagnosis? If no one really want to answer, then I just go for it. So, so this patient actually from the tap fluid analysis, we could see there's like a gout crystal. So this patient definitely had a gout. So with no doubt. had a gout flare. But the issue is why this patient the pain doesn't really improve with steroid. And also this patient having worsening inflammatory markers. So those are like a little bit of concerning, honestly. So the differential actually including the gout flare, and also we still need to keep in mind whether this patients have septic joints. So we are closely following up the cultural result of this patient. So the second day, we still continue the Solumodrol, even though we are a little bit concerned about the septic joint in this moment, but we just keep close monitoring it. And then this patient also have chronic CPPD, because from the X-ray, this patient having CPPD, but his CPPD is pre-acquired. It's not the reason that's causing this acute flare at this moment. And also because this patient had a uric acid elevated, so we also start the patient on allopurinol. So actually, this is a updated guideline, I believe, published like a few, like a 2020, the American rheumatology guideline, and then recommended starting the allopurinol, the urine lowering therapy. We can start a therapy during the acute flare if we already put a patient on adequate anti-inflammatory treatment. So this is something updated from the new guideline. Interestingly, this patient on day 3, the synovial stain comes back showing gram-negative bacilli. So as what we expect, and also we keeping in mind, this patient actually having septic joint at the meanwhile. On day 3, this patient have like a slightly worsening leukocytosis. It could be from the septic joint. It could also from the steroid effect. And also this patient have like CRP keep up trending. The blood culture has been rescinded. It's non-gross today. So now this patient had like actually pretty complicated joint issue. He had like so as for his like acute joint pain, it's a septic joint plus gout flare. And also this patient in the background, he had like chronic CPPD disorder and also osteoarthritis. So the management actually, we calling the orthopedic consult for washout, and we definitely need to discontinue the steroid, start an antibiotic. And also as for the treatment of his gout, we still need to start the patient on some anti-inflammatory medication, because steroid is not an option. NSAID is also not an option given this patient's CKD history. So we put the patient on colchicine, like relatively like a low dose colchicine. We didn't bolus the patient. We didn't load the patient. We start the patient on 0.6 milligram daily colchicine for anti-inflammatory effect. So the rest of the case is actually just like the patient had an OR, had a knee washout, and then the further infectious workup or negative. Interestingly, this patient, the culture was always negative. It's just like showing the gram stain was like a positive for gram-positive bacilli, gram-negative bacilli, sorry. And then this patient was eventually discharged on allopurinol and also the subtraction infusion. Great, I saw the comment in the chat. Cool. So, right. So this is a very interesting case. So whenever we have a patient with a like acute onset joint infusion, we always need to keep in mind the septic joint, the crystal arthritis, like all this common stuff. Especially we need to root out the septic joint, which is like an emergency. But today, because of the time, I only gonna like quickly go through the crystal arthropathies, mainly the gout and also the CPPD. So gout is characterized by intermittent painful and inflammatory joint attack in response to the crystal form as a consequence of excessive level of uric acid. So the onset of symptoms is normally super like rapid, like the symptom can progress less than 24 hours. So that's why like the onset of symptoms is very important for differential diagnosis. Just like this patient, the patient can develop from asymptomatic, completely comfortable like status to like a very severe debilitating pain within a few hours. And the affected joints often like markedly swollen, red, and also warm and tender to touch, which is the fourth classic feature of inflammation. During the early course of the gout, a single joint is always affected, and also it's more commonly affecting the lower extremity, especially the first metatarsophalangeal, the big toes. But it can also involving the knee and also the ankle. So the location of the joint cannot completely rule out gout. That's something we need to keep in mind. And then with the progression of the disease, gout can involving from like single joint to multiple joint. So if this patient having pretty like a recurrent gout and also progression of the disease, this patient may involving even the upper extremity, including the elbow, the wrist. So here's the typical symptom for gout. And then this is a picture for more advanced severe gout. So the patient with chronic polyarticular gout can represent the severe end of the disease spectrum. Such an affected person also have a greater capacity to develop a soft tissue deposit of uric acid, which we call as tophi. So we can see from the left picture, this is a very advanced and severe tophi. And with in the patient with severe tophi gout, it can also involving the patient can also develop chronic arthritis and causing erosive polyarticular disease, like what we show from the right, the picture on the right. This patient have an erosive arthritis already. The most definitive way to confirm gout is through the performance of like orthocentesis, which is send the synovial fluid cell count, the crystal study, and also the gram stain and culture. In the context of an acute microcrystalline arthropathy, there's most often a prominent leukocytosis in the synovial fluid. The laboratory will frequently report leukocytosis ranging from like 15,000 to 80,000, but some patients may be a little bit atypical. So with any synovial study with a white blood cell count above 2,000, we still need to pay like be careful about the inflammatory arthritis. And also, this is the gout crystal. This is like a uniform needle shape in appearance. And when we view the crystal under the microscope, uric acid crystal are yellow in appearance when the lens of the crystal is oriented parallel to the axis of the polarized light. So there's actually a mnemonic that is helpful to remember the color and orientation of the uric acid crystal. It's the yellow, parallel, L parallel. So namely to remember the three words that each share a double L. And then the other map is very important, is the uric acid. So hyperuricemia is the single most important risk factor for the development of gout. However, the presence of hyperuricemia in the setting of joint pain is not like single sufficient like criteria to diagnose gout. So if this patient have a joint pain, and then we saw this patient have uric acid elevated, we don't really it's not a definitive diagnosis for gout. And also for 1/4 of the patient with gout flare, their uric acid level can be normal. So therefore, the uric acid level alone are insufficient to either diagnose or exclude gout. That's something we need to keep in mind. And then we could quickly talk about the treatment for gout. So the treatment for gout mainly including the treatment for acute attack and also to prevent the recurrence of the gout flare. So there are 3 classes of medication we can use for acute attack. So we normally use like NSAID and colchicine as outpatient, but for inpatient, We can also like consider starting steroid because steroid is actually very highly efficient at rapidly reducing the symptoms. It can reduce the symptoms like reduce the pain and swelling normally within 1 to 4 hours. So it's very quick onset. The corticosteroid can be administered orally, intravenously, or can even be intra-articular injection. We can use there's a pack called PO Measure Dose Pack. It's a six days course. It's including the taper dose. So you just like prescribe the pack to the patient, and then there's like a taper dose day by day, and the patient just need to finish this like 6 days course. Alternatively, you can also do the prednisone, starting with 20 to 30 and with a taper course over 1 to 2 weeks. For NSAID, we need to make sure this patient doesn't really having like upper GI bleeding history, doesn't have like a history of CKD. There are no like a single NSAID that's like that is like favor over the other. So you can just like choose whichever you prefer, but just need to make sure you are putting this patient on relatively like higher dose of the NSAID to give their anti-inflammatory effect. So for example, for ibuprofen, probably 200 may not be enough for the patient. Normally we could start like a 600 milligram 3 times a day. And then just continue those until this patient have completely symptom resolved. Colchicine is another option. Actually, it have like a less, it's less likely to affect the kidney function. So if this patient actually having chronic kidney disease and then was contraindicated for steroid, for example, like our patient have like a concurrent septic joint, then colchicine is probably the only choice we can do. But for a patient with more advanced kidney disease, we might need to kind of like come down the colchicine dose to avoid the toxicity. For a patient with like completely normal kidney function, we can start a patient on 0.6 milligram. It's like a 1.2 milligram. It's like 2 tablets at the same time. And then you can give another dose like 1 hour apart, or just like be more simple. Just do like a 0.6 milligram 3 times a day on day 1, and then continue with 0.6 milligram daily or BID dose starting from day 2 until the symptom completely resolve. And then here's the urate lowering therapy. So both the American and European guideline recommend urate lowering therapy for patients with gout, plus any of the following indication. If this patient have stage 2 CKD or more advanced, if this patient have like more than 1 episode of attack every year, or if this patient have any sign of tophi, or if this patient have uric acid nephrolithitis, then this patient will need the urate lowering therapy. There are 3 classes of like a urate lowering therapy we are available in America: the xanthine oxide inhibitor, uricosuric, and also pegloticase. The most commonly used one is allopurinol. Honestly, I think for most of us, we need to be very familiar with their dosage and also how to titrate the allopurinol. Allopurinol should be initiated at 100 daily dose. And then also don't forget to titrate by 100 milligram every 1 to 2 weeks. And we need to check the uric acid level to make sure this patient can moving toward the target level. And then for any patient with like stage 4 or 5 CKD disease, we also need to be more gentle with the allopurinol dose. We could start with a 50 milligram per day and then titrate out by 50 milligram also every few weeks. The guideline recommended a target-to-target approach, reducing the uric acid level to lower than 6 in the patient without tophi, and then we need to keep the number lower than 5 in patient with tophi. Also, the guideline recommending concurrently start a patient on anti-inflammatory therapy. Like it could be either the colchicine or NSAID or steroid until 3 months after achieving the target level to prevent flare. But like in real life practice, sometimes we do not really start this like a prophylaxis for that. We don't really put the patient on prophylaxis for that long. Because like sometimes if the patient didn't, because most of our patients might having some kidney problem, it's just like not really that safe. But I mean, like the guideline definitely still recommended doing that. What's in the chart? So this is the gout. So we can also quickly talk about the calcium pylorophosphate deposition. So this is actually like a tricky term. So CPPD is actually like any kind of deposition of calcium pylorophosphate, like it's called CPPD, and we can always like diagnose from the X-ray. If this patient have a calcification of the cartilage, then we can already say this patient has CPPD. But like the patient have CPPD doesn't really mean whenever this patient have a joint pain, acute joint pain, he has pseudo gout. So just like our patient, he had a history of CPPD, we could say from X-ray, but actually the acute flare is not causing by the pseudo gout. It's actually causing by the gout. Any patient with advanced age had a risk factor to develop CPPD. And if the patient have like relatively younger age, then we need to consider about some metabolic disorder, including the hyperparathyroidism, the hemochromatosis, the low phos, low mag. So that's why whenever we saw CPPD from the X-ray, we need to check for the PTH, we need to check for the iron study, we need to check for magnesium level, we need to check for phosphorate level, just as what we did in this case. The P crystal is showing as a rhomboid shaped crystal, and also it's like possibly birefringent. So actually this picture can like it's having the CPPD crystal and also the gout crystal. So the yellow one is the gout crystal, and then the blue one is the CPPD crystal. They are both like parallel to the axis of the light, the polarized light, and then we can see the color difference. The treatment for acute CPPD flare is actually very similar to gout. Then why we need to differentiate this like two disease? Actually, the difference is mainly whether we need to start the patient on urate lowering therapy. So we still definitely need to differentiate these two like disease, and also because these two diseases are very similar onset in their symptom wise. So here's a few take-home points from today's talk. So for any patient with a single joint pain, the first thing we need to rule out is to identify some red flag to see whether this patient have any risk factor for a septic joint. So any patient with fever, with rash, with leukocytosis, or if this patient have markedly elevated CRP-ESR, and also if this patient the symptom fail to improve with treatment, just like our patient, then which we need to be like alert of where this patient have septic joint. Always need to pay attention. And also like a second point is the orthocentesis of the most definitive way to differentiate gout, pseudo-gout, and septic joint. So the TAP is actually very like a simple and quick procedure. So any patient had a tappable like effusion, we should always try to obtain the sample and sample lab, because that's the only way we can differentiate gout and pseudo-gout, and also to rule out the septic joint. And then there's one more point we always missing is to titrate out the allopurinol. So we normally just like start the allopurinol and never remember to touch it. So we can always see the patients on like same dose of allopurinol for a long period of time, like a similar dose, probably 100. No one touch it, no one titrate it. So that's a very common mistake we made in the clinic. So whenever we saw the patient on allopurinol and never had a follow-up uric exit, then we need to send a level and then see whether we need to touch it. That's pretty much it for the case today. Thank you so much.
Amanda, let me just comment, in your take-home points. To me, when you listen to this case, one of the main take-home points is don't rule out septic arthritis given the lack of fever or leukocytosis, right? Because, I mean, if you expect all the classic signs to be present, you're going to miss patients like this one. So this is an elderly patient who was getting antibiotics for another infection that was already present. So I wasn't expecting fever or leukocytosis, because those could have been blunted by the antibiotics. So to me, septic arthritis was number one diagnosis, all along. And I was surprised that, that wasn't, what was on everyone's mind when, the decision on how to treat the patients, the patient were being made. It was by far, I think, the leading diagnosis. So to me, that's the main take-home point. Don't expect fever and leukocytosis in elderly patients who are getting antibiotics. The other things to mention is, my understanding with gout and allopurinol was actually that most societies were moving away from giving, target goals as to, what level of uric acid you need, that they were using a lot more clinical response rather than numbers for uric acid, for allopurinol. And with that, you always want to make sure that you are adjusting the dose to the renal function, because it's not uncommon that patients with renal insufficiency, sometimes they will still get 300 milligrams of allopurinol, and then you add an interstitial nephritis to their already failing kidneys, and that's not good. So you want to make sure with that, the dose is adjusted to the renal function. The other comments I would make, these are related to when you were presenting, that you mentioned the patient had a history of wrist pain, and then the patient had cervical spine pain, and I know that this is, unrelated, but, when I heard that, I was questioning the diagnosis of osteoarthritis, right? Because, I mean, wrist pain is not the typical location for osteoarthritis. A cervical spine, maybe, it's not the typical, the most prominent spinal location, but it could be. But rheumatoid arthritis would be, would have been a lot higher on the differential at that point when we were considering that the patient had wrist pain and also the, the cervical spine pain. And with cervical spine, you want to be careful, because if you miss that diagnosis, patients with rheumatoid arthritis who have cervical spine involvement, they may have a subluxation of C2, and that may make them quadriplegic. So particularly if they're going to get intubated, when the anesthesiologist hyperextends the neck, they can go quadriplegic. So you have to make sure that you don't miss a diagnosis of rheumatoid arthritis, particularly if a patient's going to go through, through some anesthesia of some kind.
That's a board question right there. And I apologize because I unfortunately missed the beginning. Amanda, could you go to the first slide? Because do we know what antibiotics? Because then I do want to kind of correct a little bit what I wrote, because I actually wanted to write it, especially if someone's been on antibiotics, but I also wasn't here in the beginning. Because this, everything in terms of points, and then just even the gram stain and culture, even if but do we know what antibiotics they were on before? Because Dr. Pigolini made a point to say that he had been on antibiotics before.
So this patient was on cefazolin before for his cellulitis. So initially, why we're not that concerned about septic joints? One is the joint pain is actually on the other side of the prior cellulitis. The cellulitis on the left foot, and then the joint pain with the right the right knee.
So,
and then
so
like,
that, I think that's very interesting because basically what you're saying is that it's not that the joint became infected by, being next to the infection. If anything,
so
we should
we're
think.
kind of curious where that infection coming from. Actually, we don't really find the source what's causing this like a septic joint. What we're suspecting, because the culture was showing gram-negative bacilli, and then this patient had the UTI. We just wonder whether it's from like a transient bacteremia from this UTI. Those are all like guesses. We don't really having a definitive like.
It's a challenging case, but at the same time, like I agree completely with Dr. Pigolini that like, for me, when I was looking at number one is getting that cell fluid right away, the synovial fluid, and really talking to a patient that this is what's going to help the management. And then as soon as you get that, you err on the safe side, and it's more of like coverage. Do you do vein with ceftriaxone? Do you need that MRSA coverage or not? Because that's really what you're doing with the vein. Or do you just need the ceftriaxone? And then that gram stain usually shows up right away. I'm surprised it took a few days for it to show up. And then we call micro at times also, and that determines like what you're going to do. But regardless, this patient gets treated as septic arthritis. Even with the cell fluid, because he's right at the 43,000, but we're not very black and white where we say 50,000 and it has to be 50,000. No, because you have these other confounders that allow you to kind of say, he'd been on antibiotics before. That's probably why the cultures were negative. What's going on was the transient bacteremia that we just didn't capture with the blood cultures. But that's, so I think those are more of the take home points. And, I really gave a great question because like at what point do you start antibiotics? I think with this and the information I just got from Dr. Pigolini, I would have kind of, been a little bit more broader and then narrow as you get more information in terms of the antibiotics. And I think it was reasonable just to do the ceftriaxone alone in this case.
The other thing that I would mention is that when you mentioned that the patient had dysuria, something to include on the differential would have been a reactive arthritis as well, right? Because you want to think of, Reiter syndrome type of picture as well.
Right.
Thank you, Amanda. That was a great case.
Thank you, Dr. Pigolini.
I want to echo all the comments in the chat. It was a fantastic presentation. Thank you so much for bringing this case.